So I'd like to now introduce Dr. Kevin McVary. He is known to a lot of you. He's a urologist, and he's a very prolific researcher. He did a urology residency at Northwestern and also did a research fellowship. He is now at Loyola University Chicago in the Stritch School of Medicine, where he's the director of the Center for Male Health and also professor in urology. Prior to that, he was at Southern Illinois University and also chief of urology at the VA Lakeside Medical Center in Chicago. He has published over 400 publications. He has been the PI of over 100, I think it's over 120 is what I read, clinical trials. He's very well regarded in research circles. He's a frequent collaborator with basic and translational scientists, and that's how probably a lot of you know him. And he's also associate editor of the Journal of Urology. We are very lucky to have him here today, and you'll see him later. He's going to be a guest poster judge at our poster session today, and he'll also be with us at dinner. So without further ado, I'd like to welcome Dr. Kevin McVary. Is that yours?
No, that one. There you go. Yeah, just take it there.
All right, and then slideshow.
Probably there.
Yes.
Here.
Why am I doing this?
Yeah.
Okay.
Come on, you. I'm Mac based, so you know I have a disability. Okay. Yeah, she keeps flicking on it. There we go. Thank you for that kind introduction, Chris. It's an honor to be here to speak to you today, and I am setting my watch because McVary stay on time and on budget. So it's really an honor to be here. It's great to see a lot of old friends, and I'm sure I'm going to meet some at the poster session. I'll be the good reviewer, okay? My disclosures essentially focuses on erectile dysfunction and BPH. And the objectives I wanted to show are here. I won't read them to you, but I just want to say, don't lose hope, become a scientist. So you're probably wondering, what's this all about? Well, this is picture day in the Chicago Public Schools. And this little boy wore a Packer jersey to his picture, and nobody will sit with him. Why am I putting that up here? Because that kind of speaks to what I'm going to talk to you today. And I don't want to be the Debbie Downer, but there are these very strong forces coming at people like me, clinicians, and I think that these are significant. They're going to impact the world. They're going to impact all of us. But I think there is also light at the end of the tunnel, and to the young investigators, that's what I want to transmit. So what's the first message? The message is that healthcare BPH is really expensive, $1.9 billion in 2013. You can imagine that's only getting worse. This is a paper where we grabbed all the costs in the Medicare system and in private insurers in the US. So it excludes the VA system and all like Obamacare programs, Medicaid, all those kind of state-run programs. And that's at almost $2 billion. And there are shifts, you know, from office into ambulatory settings, depending on the technology and blah, blah, blah. But the message is that it's huge. It's coming at us. And I think that's an opportunity for you. The other is has to do with people like me who have gray hair. And that's that as the burden, as these large number of people come into needing BPH care, lower urinary tract care, the workforce is really not set to handle it. So the global number of years living with disease, that's the red line, you can see it rises steeply. And when compared to other urologic diseases, it dwarfs them. And that BPH has such a tremendous load to the system. And at the same time, the ability of urologists, of clinicians, and APNs, et cetera, to handle this, this load is going to become increasingly less able. So here's projections for American men. You know, there's a demographic that does level out a little bit, but worldwide, this is going to continue to rise, and people are going to be looking to you for help. on this. And at the same time, healthcare professionals, in order to handle these things, are just, totally outmanned. And it's not just a US system. We have South Korea shown here as well. It's the red line. We are really outgunned. But again, people are living longer, and as they live longer, they have the opportunity to develop BPH LUTs. So it's kind of that double-edged sword. And again, I think as less developed countries start to live longer, that this is going to impact you and me. And so, Debbie Downer here is trying to find a way to turn lemons into lemonade. And it's my segue into kind of the first approach is that one technique, one thing to look at is potentially preventative, complementary, and cost-effective strategies to affect LUTs BPH. Why do I say that? Because that's a big question. And I think the big question is one of the goals for young investigators, to grab onto the big questions. Say, well, why? Well, one, there's interest. Two, there's need. And three, it's called a career. With answering big questions, you can stay in the game. So here's one of my favorite slides that comes from the Olmsted County, which was a kind of long-term epidemiologic study around the Mayo Clinic. And it shows the very modest increase in prostate size over time, like 1.6% per year. Each one of these little black lines is one individual patient whose prostate was measured over time. So the aggregate of all these black lines is the red one. And I think the best example is this fellow right here. His prostate is he starts out very big, and it's continued to, the slope of rise of his prostate is really quite steep. And then his age-matched control, someplace down here, is almost baseline. Now, when these two guys come into the hospital or to the urologist for care, they're going to be treated the same, because we're looking at it in this. Here's the average guy. This is our average approach. But I would say these guys have two different problems. But we don't discern that. The phenotype isn't there. And again, big question. So I think one big question I want to use as an example is this idea of obesity's impact on urology. You're well acquainted with the epidemic in America. You've probably seen this 100 times, this type of slide, but basically, it's sweeping the US, or has swept the US, and soon to sweep the rest of the world. So again, big topic. And there's this very strong relationship between obesity and LUTs BPH. When I was a resident way back here, I read this paper and was really intrigued by it. What was interesting, looking at predictors for men who got BPH, and it was BPH not defined the way we would do today. That's true, because it's mid-80s, right? Our concepts have changed. But the only predictor of that risk was their BMI. That basically a reflection of obesity. You're probably aware, if we look at some of the placebo arms of these big trials for 5 ARIs, finasteride and dutasteride for prostate cancer prevention, if you can look at the placebo control arms and then look at risk factors, you can see that, again, obesity is a very strong predictor, and emerging this idea of waist-hip ratios, or hip-waist ratios, however you want to express it. And then Giovannucci, he was the investigator that had prostate cancer vasectomy. Other than that, he's been a great investigator in my own view. That was a problem. But he had also showed this very strong link. And then lastly, this idea of physical activity as a protector. It first emerges in this NERI, New England Research Institute paper. And I'd like to kind of develop that further. The other idea is BMI may not be the right idea. Other investigators showed that it's really this waist-hip ratio. In a sense, it's the beer belly. It's not just fat, it's where that fat is. It was a key concept in my own view in terms of trying to reveal what is actually happening. On composite, you can look, there's a very consistent story about basically heart disease, hypertension, cholesterol, diabetes, all the aspects of metabolic syndrome and the development of LUTs BPH. And it's not just the fat and where the fat is, it's when did you get the fat? Did you develop it early? Less risk. If you got it at middle age, high risk. Kind of the opposite of what I would have thought. But anyway, doesn't matter. I'll move along. all this epidemiologic data, what does it tell us? Well, there is a consistency, but there's lots of bias. There's an evolution of treatment. First, we were talking about a DRE as BPH, then surgery, then medicine. So the definition of BPH changed over time. You have to take that into consideration. This is what the students learn in medical school. Prostate get big, me urologist, me cut out, patient get better. That is true. And if you're really insightful, you say, oh, dynamic tone, smooth muscle, blah, blah, blah. Yes, all that's true. But I think as the primary cause, it's probably not true that there's all these other factors which are opportunities for investigation that really drive Let's BPH. Now, I'm not saying that there isn't something about enlargement, because I know that it's there, but it's these other factors. So one segue, does anyone know who this is? Yeah, so Diamond Jim Brady. So he's the guy, the bazillionaire of the day who funded the Brady Institute at Hopkins and also at Cornell. He was known for all this diamond stuff he wore. He donated all this money to urology research because he had BPH. This is his daily diet. And I'm telling you, I think he had metabolic syndrome, and this was a misdiagnosis from the very beginning. But think of all the good things that happened because of that misdiagnosis. He funded all this great urology research. Okay, back to reality. So I've already explained, I think, sure, the anatomy, the bulk, the things that we've learned in time are true, but these other factors can have an influence. And I look at that as, as great aspects for investigation, additional investigation. Now, a lot of you folks are looking at some of these topics. Low-grade inflammation is one that's coming to my mind as I look at Will, but I'm going to focus a little bit on sympathetic hyperactivity, something I'm interested in, because sympathetic hyperactivity is one of the components of metabolic syndrome. And as a man develops different categories of metabolic syndrome, his symptom score has a nice linear relationship with it. Is there a mechanism? There's one we propose, there's other ones, but you can imagine that as these inflammatory factors rise associated with obesity and autonomic tone, there's effect in the way insulin interacts with the receptor, and it can be inhibit apoptosis, et cetera. We took a large survey of men and women living in Boston, the Bach study, and measured CRP, a systemic measure of inflammation, tried to relate this to their symptom scores. There's a very consistent relationship between level of inflammation and the development of, or the presence of lower urinary tract symptoms. I'll skip this one and get right into the fight. And so one of my messages for the young investigators is listening to your mentors. And one of the ones I had very early when I became an attending is Dr. Chung Lee, who was the head of research at Northwestern. And we would have I call them fireside chats, but we would sit, he would talk. But one time he said, McVary, if you cut the nerve to the muscle, the arm withers. What happens if you cut the nerve to the prostate? I'm like, I don't know. I have no idea. So shrinks. I'm looking for the right answer. He didn't know. But he asked me if I would work with this guy, Wang, who I knew from another project I was doing. I said, yeah, sure, I can do that. And he insisted that I did it. And boy, it was really a smart idea, and not forcing me, but really pushing me in that direction. And it's true, you cut the nerve supply to the prostate, it involutes drastically, has lots of potential repercussions. If you feed a rat a very high fat diet, this is work I did with Kevin McKenna, a neuroscientist at Northwestern, prostates, rats get fat, yeah. If you feed them a Western diet, basically a lard diet, they get fat, but their prostates grow out of proportion to the rest of their body weight. I showed some of this work at a meeting, and Bill Steers, so God rest his soul, who was a great urologist and investigator, came up to McVary, it's stupid, you cut the nerve, of course, the prostate shrinks. He did a better experiment looking at spontaneously hypertensive rats that have this autonomic hyperactivity based and a genetic relates to nerve growth factor, and did a better experiment than we ever did, but basically showed, this autonomic hyperactivity drives prostate size, prostate growth. It goes from, causes basically hyperplasia. And then even did more, where he showed he used to put in blockers and agonists, and you can basically tease away the influence of autonomic activity on prostate growth. So why am I saying that? Because I listened to the critic, and he was very critical of me publicly, a little hurtful, but I mean, because I was young and sensitive. But I got over that, and we became friends eventually, a couple decades later. But long story short, I think listening to that negative review, listening to that negative comment, you can make it work for you or against you. And I think in this case, I think it really worked for me. I got turned and did better studies thereafter. So Nick's message is opportunity. When opportunity knocks, you got to grab it. So there was a famous study, the MTOP study. The urologists certainly know it in the crowd. It was a really landmark study in the use of medical therapy for BPH. And most clinicians base their current care on that. And it's how I kind of got my tooth warmed up in the NIH, and it's worked out pretty good. But as men were going into the NIH trial, we got an opportunity to do a sub-study. We did it right, we got IRB, blah, blah, blah. We went through all the paperwork, and we took these men in off to the side before we enrolled them, and we studied their autonomic activity, trying to link back to this animal work that Kevin and Dr. Lee and Dr. Wang had encouraged me in the years before. So this is something that they couldn't do, but because I was a clinician, I could make that happen. And so basically their collaboration pushing me kind of started me on this project. So we knew there were certain clinical factors that drove autonomic tone. They're listed here. And then we tested patients on tilt tables. And, you know, this is not the kind of thing you want to do. It's a kind of experiment you want someone to do for you. But basically, in a dark room, you have patients all mellowed out. You tilt the table 70 degrees, and if they don't vomit on you, their autonomic activities go wild. You can measure these. And then, of course, we had characterized them clinically as part of the MTOPS enrollment. And basically, a very strong relationship between autonomic tone, and these are symptomatic men, in order to be enrolled, and their symptom scores. And very strong, very consistent. The AUA symptom score, the impact score, all the ways we score patients, this autonomic tone was much higher, basically very strong linear relationship. We had also demonstrated in a simpler analysis, also a correlation with prostate volume, both total prostate volume and transition zone. So anyway, I thought we were on to it. A couple of years later, very interested in the relationship between erectile dysfunction and BPH because those two diseases cohabitate. My own view is they're two manifestations of one disease. And again, autonomic activity measured, strong correlation. I thought, hey, you know, maybe we just made the link. So putting this whole picture together, which took a neuroscientist, a molecular biologist, a clinician, umpteen fantastic, great nurses, kind of came up with this idea that we have factors which we know drive autonomic tone. We know from the animal work, which I really skipped over, that autonomic activity looks like it drives growth. We had this information from the MTOP study that shows autonomic tone correlated to prostate volume, and then this possible link to erectile dysfunction. Why am I saying this? Because then this became a window to intervention. Look like they influence it. We have a potential trial. Alter caloric intake. Can you reduce LUTs? Can you reduce it or can you prevent it? Change obesity, change activity. These things influence autonomic tone, and the idea is, hey, you got your pathway. Why does this even matter? Well, as it turns out, obesity relates to reactivity to medication. That this is looking at PD5 inhibitors, Viagra for LUTs, very first way we ever did this trial. We did at Northwestern looking at this. But response to drug is also influenced by obesity. And again, I thought that was interesting. And here I collaborated with a group from Italy that measured metabolic activity, metabolic syndrome, and response to surgery. And what do you think we found? the higher amount of autonomic activity, the higher level of metabolic syndrome, a worse response to surgery, that it was probably not obstructive at all, more irritative. And again, in that cohort of men who had surgery and responded or didn't, very strong correlation to hip waist ratio. That autonomic tone looks like it prevents recovery in the sense they have a different disease. And we see this again and again. Now, Elizabeth Platt, she's a prostate cancer investigator at Hopkins, but before she went to the dark side, she was really interested in BPH. And that's where I met her. And she did this really fantastic paper, which is completely unappreciated by the world. And I espouse it. So it's a long time ago, early in her career. What she was also interested in physical activity and BPH, again, defined different than we would today. But she did something really cool. She had measures of activity, physical activity on this axis, and then odds ratio for Lutz BPH. And you can see basically, basically the men who are physically inactive here have a higher risk, and men who are more active have a lower risk. That's basically, but the great thing is she also asked people how much they watch TV. And that's the difference between the white and the black lines. Now, this isn't data mining. She did this actively. And the people who watch no TV, very low risk of Lutz BPH, even if they're physically inactive. And people who watch lots of TV, very high risk. So TV causes BPH. No, no. TV watching is a great. People lie about how much exercise they do, basically. But if you say, hey, tell me about the shows you read, or you watch, you can estimate their time sitting watching TV. And it really discriminates. So she does a fantastic measure. So, and then lastly, a pilot study done at UCLA, never repeated, where people were coming into a weight loss camp, Pritikin camp, and they did serum levels and took serum and then plated these on epithelial cells from the lab. And you can and looked at proliferation of prostate epithelial cells. For controls, they just took the coaches, the life coaches who are all into the Pritikin lifestyle, took their serum. You can see much reduced proliferation. And then after just 2 weeks of these obese patients being in the trial, they really approximate the controls. What's the message? There's an opportunity for intervention. And that it may not take years and years in order to do that. And so I look at that as the teaser on why these interventions are good. Now, you just can't do those pilot studies, right? You got to have studies from different direction. And again, back to the NERI, New England Research Institute. Why did I get involved? I think the reason I got involved because I actually answered their emails. That's the only way I think that they asked for me. But and that's a message. I'll get to it later. We had this big cohort of men and women. We followed them year 1, 5, and 10. So we followed the same group of community living people over time and looked at their risk for development of BPH. What do we see? At baseline, people who are very physically active, over time, 5 and 10 years, very low risk of developing Lutz BPH. Couch potatoes, people with low physical activity at baseline, they develop it at very high risk. Smoking, that same heavy smokers more. And I can just tell you, as an Irishman, I was so profoundly happy about the alcohol, had no influence. So the message is not just the cross-sectional appearance, but also the longitudinal appearance. You see the strong relationship. So you start clicking all the boxes. You got a story. So where do we go? Well, you could do an intervention, or you could do like policy for prevention. So we know there's different factors which certainly influence Lutz BPH. I think I've talked about that a little bit. Is it physical activity or is it caloric intake? You know, how do you do this? I work as part of all these projects. I got involved with people who do weight behavior modification. And they tell me, you know, Kevin, you really can't separate caloric intake from physical activity. You're not ever going to be able to answer that. When people are physically active, their caloric intake is going to be better. But anyway, I think you see the idea. do you do an intervention, or you do an intervention, take men with LUTs, have them lose weight, exercise, and maybe improve them? Or again, do you start at a younger age group and say, hey, over time, can we make things better for America? So back to this overwhelming picture, I think you get the idea of why ideas from you folks may have a real influence on this. Now, I don't know if you know this guy. I was late to the game, but kind of the father of nanotechnology, Richard Smalley. He wrote this book, Be a Scientist and Save the World. And I really think that's your mission. So I was asked by Chris if I could just say a couple things about building a translational science team. And so I broke it down to the question, you, the clinician, and support from somewhere. So the question, I think I've tried to hit it a couple of times, that your question has got to represent something impactful. It's got to be novel, and it's got to be innovative if you want attention. And so I say you look for the big questions. Where's the unmet need? And I just use obesity as kind of just an example of that. Carol Podladzik, who some of you know, first my research assistant, and then now I work for her. But she's made a career out of looking at the side effect of erectile dysfunction from radical prostatectomies and diabetes. Took a very, because it was unmet and it was a real problem in urology field. She saw that, developed her entire career from really just side effect. So it can be done. Message to young investigators, put all kind, I tell the young, we have lots of pokers in the fire, and the ones that get hot, then you'll take them out. But you got to be focused, but you also don't want to miss fruit on the other side of the tree. So what about you? Well, I'd say you're likely to be young, and you're going to be energetic and willing to take the time, because it's really going to require that. And the one thing I've learned, man, the collaborators who are the diplomats, they're the ones that really succeed. And it's always about people. All the problems from the lab you get over, you fix it or whatever, but it's the people. So always be the diplomat. And I'd say try to be the collaborator, be the one that's going to create that synthesis. And it can totally be done. I can tell you, if a urologist can do it, you can do it. And I want to emphasize those fireside chats that I had many times, some were, not spanking sessions, but hey, McVary, maybe we should redirect. And others were like, keep it up, encouraging, because when you're a clinician and doing this, you don't know if you're a fish or you're a fowl. Am I a doctor? Am I a scientist? What am I? And you just kind of accept, you're going to be a little different than anybody else. And then I want to say a few things about collaboration with clinicians. You don't need someone who's going to be a Nobel laureate or one who is. You just need someone who can work with you. What's he or she going to bring to the game? They got to have something that they can offer your project and offer you. And they got to be interesting to be around. You don't want to be sitting with a curmudgeon or a Debbie Downer. And I would say, show up and sit down. Show up, sit in front of the person, meet, have the chats, and ponder. It doesn't, and not everything has to be goal directed. Like, what do you think about this? What do you think about that? You'd be surprised. I would say the clinician, he's got to be someone willing to learn and not assume that he is the boss. I've seen a lot of guys go down that way thinking, hey, I'm the boss. I got an MD. Doesn't work that way. They got to have a collaborative spirit, and you need to look for them. Now, they've got to be interested, and that means you got to be talking with them, and that requires time, and that's always going to be a problem. And I blocked out time, and then the investigators I worked with were pleasant to me and understood. And then I look for, hey, are they responsive? Like, do they respond when I send them an email? Do I get an answer? When I send them a manuscript, do I get edits? And then I said, create the paper trail, meaning when Dr. Lee told me to go sit with Wang and do the experiment, what it did is it established on print in a paper that, hey, I was already in this neurobiology game, because otherwise I'm just a urologist. So that helped me when I started submitting grants. What about support? Well, I mean, the easy one is, hey, obvious one is you're going to get it from your chair or your school or something, but your clinician's going to have access to grants that you may not know about or may not have access to. And you can use that. you as a team, you folks can use that. I applied to like every intramural grant, every place I have ever been. And one of my very first rejects of a paper, I went to the statistician. I'm like, oh God, we got rejected. He goes, don't worry, Kevin. They just helped us rewrite it. So I learned, well, okay, that means I can fail and I can rebound, and I'm going to learn from that review and write it different to another journal. So anyway, I think the message is clear. And then this idea of pilots, they're all over universities. So, they're in hospitals, they're in schools. I got development grants from community groups, who wanted to sponsor innovative stuff in Springfield, Illinois. So I was able to do that, and I think you can do it. And, local champions of innovation, you want to meet them, you want to be there. And then I call them the sugar daddies. Those are grateful people who want to support young people, and those people are out there. And at Loyola, we have a kind of an organized STAR program. It's on a training grant for students. But these are medical students potentially interested in research. And I got so much love. I'm taking everyone I can get to work with me. And I think I started on the pathway because another clinician said he was too busy. I'm like, oh, easy. Now, I get these students in, and it works out pretty nice, and it's totally good for them. A lot of these go on into urology, and then the resident interactions work the same way. And then my latest acquisition is that engineering students need capstone projects, and we got projects. We got ideas for projects. So they bring a lot of not just the resources, but the manpower and the energy into finishing these projects. So I can't say enough about it. So I'm trying to progress here, sorry. And then lastly, freebies. There's a lot of freebies, places where you can acquire stuff that helps. Oh boy, going over. But I'm going to wrap it up. I won't be behind too bad. In the last 3-4 years, all free, we were able to use leftover specimens from cadaver labs for some of our STTR grant. Because we're interested in penile tissue and some of the ways the may respond to stress and structure. I set 3 or 4 material transfer agreements, like with University of Chicago, Northwestern, University of Illinois, Chicago. I set all these up, and because there's a lot of specimens from other institutions that they're going to throw away, and if we set up these agreements, then we can use them for our stuff. And we don't pay for that. It takes a little time. And we're always looking for tissue sources. At Loyola, we can't do transgender surgery, being a Catholic institution, but we can use those tissues if they're procured at other places. And a lot of urologists aren't interested in any kind of study. We can accept those tissues, and we've been able to use them again, freebies. And then even primate studies, like basically things which are not tissues that are not otherwise under an IRB, if they're not going to be, if they're going to be harvested and tossed, then we've been able to accept those. So totally above board, all IRB approved at Loyola. But the idea is that these resources are there, and they're basically available for you. So summary is this: you think this is going to be really simple, something like this, but the whole process is quite complex. But again, I'm telling you, if a urologist can do it, so can you. So last and least, and only 3 minutes over, thanks to Dr. McKenna. He's a brilliant neuroscientist at Northwestern, kind of mentored me through my whole career. Carol Podlazic, who used to work under me. I work for her, and I think that's great. But and then you're probably aware of Brian Helfand, Tim Searle, a molecular biologist, a urologist, molecular biologist, and Tim Searle, another neuroscientist. And then the group at NERI, who kind of allowed me to get involved in all of their epidemiology studies. I think really because, as I mentioned, I answered the phone. At any rate, I went slightly over. Sorry about that. Thank you for your time and consideration.